Okay, well, welcome to everyone. Today I'm going to be talking to you about three so-called parasomnias. I'll explain what that is in a moment, namely sleepwalking, sleep terrors, and nightmares. Parasomnias are undesirable or abnormal behaviors, perceptions, or emotions that we can experience, usually during sleep, but also in transitions between sleep and wakefulness, so either when we are falling asleep or when we are about to wake up. They can be relatively benign in nature and not cause much distress, or as we'll see in some cases, they can be rather serious and have important negative consequences either for the sleeper, family members, or often both. Parasomnias are typically divided as a function of what sleep stage they tend to occur to. So very broadly speaking, here you have what's known as a hypnogram, which I think you saw in one of the earlier talks, which basically shows you a bit what sleep stages you go through once you fall asleep. And so a cycle of sleep takes about 90 minutes, and as you fall asleep, you go into deeper sleep. Here, what is appears in red portion. And as the night progresses, you have more and more what is called REM sleep, rapid eye movement sleep, where most vivid dreaming takes place. And so some non-REM parasomnias, those that tend to arise primarily out of slow wave sleep, tend to occur very early in the night period, usually in the first hour and a half or two, because that's where most of the non-REM sleep or deep sleep occurs. Whereas parasomnias associated with REM sleep, we'll be talking about nightmares, tends to preferentially occur in REM sleep. So that'll occur not here, where sleep terrors and sleepwalking occurs, but more towards the end of the night, where REM sleep tends to take place. So sleepwalking is one of these non-rapid eye movement parasomnias, and it's typically characterized by mental confusion. There's various kinds of motor behaviors, which we'll describe shortly. There's misperception, relative unresponsiveness to environmental stimuli, people that are around, things that they may see or misperceive, and they might forget that they had an episode or forget little parts of it. We'll return to that issue a little later on. When sleepwalking occurs in young children, it's usually something that occurs in a transitory fashion and is relatively benign. Most children will naturally grow out of it. But as we'll see, not all of the time, whereas it is generally adults who suffer from sleepwalking that will come and consult at a sleep clinic, and usually because they have either injured themselves, placed themselves in dangerous situations, or at times have even injured their bed partner or other members of their family. The kinds of behaviors sleepwalkers will evince can vary from something that is very mundane and simple, sitting up in bed, mumbling, pointing at a wall, playing with the bed sheets, things of that nature, but they can be surprisingly complex. And so people might get up, rearrange furniture, they might attempt to cook a meal, eat, though sometimes the ingredients they use are creative, but you may not want to eat a sandwich combining relish, for instance, and peanut butter. So the kinds of things they will put together sometimes is not the best choices. They may leave the house, hence be in danger, often inappropriately dressed for the weather. And there's also instances of even driving automobiles during episodes. And of course, all of this also can have medical legal implications. There's also a few very rare cases where crimes have been committed during such episodes. While a person is sleepwalking, their eyes are generally open, which is what allows them to navigate in their environment. They can open a door, they might see someone, they will walk down stairs, pick up an object, so their eyes are open. They can be either emotionally very calm or very agitated. They will often either spontaneously return to their bed and fall asleep again, or fall asleep somewhere else. And the episodes, because of these behaviors, can vary a lot, might just go on for a few seconds, and they can last dozens of minutes. Sleepwalking is something that's much more common in children than in adults. So in preschoolers, Generally speaking, somewhere between 3 and 5% of preschoolers will have an occasional episode. The peak incidence around 10, 11, maybe 12 years of age are at about 15%. And then it decreases throughout adolescence. And finally, in adults, it's about 2 to 4% of adults that will have frequent or chronic sleepwalking. I mentioned earlier that most children will outgrow the disorder. It will just go dissipate on its own. But in about 25% of cases, children with frequent sleepwalking may continue to be sleepwalkers as adults. And there's not any significant differences between men and women as to the frequency with which people will have episodes. Now, why do people have sleepwalking? There's at least 2 major factors that contribute. One has to do with genetics. And so genetic factors play a key role in whether or not someone will be a sleepwalker. So about 80% of adult sleepwalkers and children will have at least one other family member who will also be a sleepwalker. Children of parents, one or both, who are sleepwalkers are much more likely to be sleepwalkers themselves. And large-scale studies of monozygotic twins, so twins that are identical twins, share their genetic material, are 5 times more concordant for the disorder than are dizygotic or non-identical twin pairs. But genes aren't the only factor. Psychological factors also can play a role, and these especially come and modulate when you will have episodes. Why do you have some in this period of your life or on this particular night and not others? About 1/4 of adult sleepwalkers present with a mood disorder, such as an anxiety disorder or depression, but that still means that about 3/4 of them do not. In early childhood, sleepwalking can be associated to separation anxiety or stressors, so beginning school, going to daycare, parents who are undergoing divorce, moving to a new city, all of those kinds of potentially stressful events. And we know that anxiety and especially stress can facilitate the occurrence in predisposed people, and this is true of children and adults alike. Finally, sleep deprivation, whether it's chronic, that is, we are cutting back on sleep a little bit every day, or acute, you do an all-nighter, or is also another factor that can contribute to your chances of having sleepwalking if you are so predisposed. Now, one question that people often ask are sleepwalkers awake or are they asleep during their episodes? They move around their environments, but their judgment seems to be altered. They sometimes don't recognize people. They do weird activities that they may not be doing if they were fully awake. And concomitant with that is, are they dreaming during these episodes? And so the answer to the first question is they are neither awake nor asleep. Their brain finds itself in a state where both processes of wakefulness and sleep coexist. And so you can have some neural structures within the brain that are still asleep. And so that explains things sort of lack of judgment, memory impairments, behaviors that don't quite necessarily make sense. But other areas are awake, so they may recognize a person, they see and react to various degrees to their environment. And it's also what allows them to sometimes perform very complicated activities, or also activities that require a fair degree of dexterity. The question of whether or not they are dreaming during their episodes, it's a bit more complex depending on what we mean by dreaming. But we do know that many sleepwalkers, at least the adult ones, will at least on occasion report very short dreamlike, unpleasant dreamlike mentations that accompany their episodes, and these kinds of dreams that they're having explain what they're doing. It might not make very much sense once they awake, but what they were dreaming about or those thoughts going through their minds while they were acting their episode makes sense during the episodes itself. So they're not dreaming in the sense that, in the classical sense of the word, where you are asleep in bed and your eyes are closed and you're immersed in a virtual world that has nothing to do with the environment you are asleep. Sleepwalkers are navigating in the real physical world, but with some misperceptions that are guiding their behaviors. In terms of clinical management, one of the most important things is to ensure that the sleeper has a safe environment. Sometimes that may mean having heavy blinds on the doors. If they are sleeping in an unknown, unfamiliar environment, hotel, camping, whatever, make sure that objects over which they may trip, for instance, if they have an episodes, are removed. In the regular home, locking the doors, things of that nature. If the disorder requires treatment, there's usually three main venues for treatment. One of them is hypnosis, including self-hypnosis. The other one is what's known as scheduled awakenings, which works very well in children. And there could be medication-based treatments. In children, there's something called anticipated awakenings, whereby basically the parents are instructed to keep track at which time the episodes tend to occur in their children. And then they wake up their child, usually about 15 minutes before these episodes tend to occur, and they do this for about 4 consecutive weeks. This is something that works quite well in children. I mentioned hypnosis, self-hypnosis, that can work well in adults. And although there are pharmacological treatments available for sleepwalking, many of them have side effects. Sometimes when the medication is discontinued, the sleepwalking can come back worse than it was previously. So it's something that is better used in particular phases of the disorder. For instance, if someone is going camping with their children, want to make sure they don't have an episode with other children around, things of that nature, or in times of particular stress, but it's not really something necessarily good as a long-term solution. The other parasomnia that occurs out of slow wave sleep is what is known as sleep terrors, or commonly also as night terrors. And so these are sudden, they appear like awakenings out of, again, deep sleep, except that here they're usually accompanied by a piercing or blood-curdling scream, very activated autonomic system, so elevated heart rate, respiration rate, the person can be sweating, and there's really this overwhelming sense of fear or acute panic. Generally, the episodes, just like sleepwalking, will occur about 90 minutes after the person has gone to sleep, or even before. So in the first phases of sleep, where slow wave sleep or deep sleep predominates, and they will sit up bolt right in bed, scream very loudly, and again with a panic-stricken expression on their face. One of the key characteristics of sleep terror is that the person is unconsolable. If there are parents here who've had a child who's had sleep terror episodes, you can probably relate to this, because you can pick up the child and they don't respond to you having them in their arms. They look at you with a glassy stare or right through you as if you weren't even there. And again, nothing we say or do tends to console the children, and the same can apply to adults. Once the episode subsides, usually the person will fall back asleep, and typically, whether it's children or adults, will not remember having had an episode upon awakening in the morning. Prevalence, again, just like for sleepwalking, particularly for sleep terrors, is hard to know because it depends who you're asking. Here you have to ask the parents. They sometimes confuse it with other sleep disorders, such as nightmares. But basically what we know is that it is much more frequent very early in the child's development, and then decreases rather rapidly. So over 1/3 of toddlers and young children can have occasional episodes. By age 5, this proportion has decreased to about 13%, and by age 13 it has tapered off to roughly 5%. But one thing that is most interesting is that over 1/3 of children with frequent sleep terrors will go on, the sleep terrors will disappear, and then they will go on to develop sleepwalking. And so sleepwalking and sleep terrors, we believe, have the same underlying pathophysiology. They are two manifestations of a same common type of underlying disorder. It is also not uncommon, by the way, for adults to have episodes that combine the two. So they may have a sleep terror, and then the sleep terror will evolve into a sleepwalking episode. In the general adult population, it's about 2% of adults who report sleep terrors. Here too, just like with sleepwalking, no significant gender differences. Genetic factors play a very important role, and again, probably play the similar role in both sleepwalking and sleep terrors, and the treatment options tend to be the same as with sleepwalking. Now, I've mentioned that many people tend to confuse sleep terrors with another parasomnia, this one known as nightmares. Nightmares are ubiquitous. Almost everyone will have at least a nightmare on occasion. The themes that characterize nightmares usually involve threats to either our survival, security, or emotional well-being, self-esteem, things of that nature. But these experiences are very different from sleepwalking or from sleep terrors. Usually when the person awakens from a nightmare, there's an immediate sense of relief. Oh, gosh, it was just a dream. And so they are relieved. They immediately recognize where they are. They're in their bedroom. They are safe. If there's some autonomic activity, heart rate, respiration rate, any increases you observe tend to be much less dramatic than what you see with sleep terrors. There's usually no cry for help or these piercing screams. And they occur not in the beginning of the sleep period, as we see with sleepwalking and sleep terrors, but in the last third of the night during REM sleep. So if you remember this graphic, it tends to occur in these later cycles of the sleep period where REM sleep predominates and where it lasts for longer periods of time. In terms of prevalence, nightmares I mentioned before are very common. In children, over half children in some studies will report having nightmares at least on occasion. There tends to be a peak that occurs somewhere between the ages of 6 and 10. And what is often considered clinically significant frequencies of nightmares, which is once a week or more, occurs in about 2 to 6% of adolescents and adults alike. And about 5 to 8% of the general population will report having a current problem with nightmares. And so it is clinically frequently seen a problem, unfortunately one that is often disregarded, or one in which patients often think there is nothing that can be done about it. Nightmares are just something that happen to us when we're asleep, but as we will see shortly, there are things that can be done. Finally, we know that nightmares are much more common in women than in men, and this difference tends to arise somewhere after the ages of 15 or 16 years of age. Nightmares can occur in otherwise relatively healthy individuals, but they're also associated with a very broad range of psychological and psychiatric conditions. They go from anxiety to depression to neuroticism, some personality disorders. So there's really nothing specific to nightmares. They really characterize quite a spectrum of potentially important psychological disorders. We know that they are reactive to stressful life events, be they good or bad. Some stressors, new job, can be exciting, but also give rise sometimes to nightmares. We do know that they are very common in individuals who've been exposed to trauma, and it's one of the defining characteristics of post-traumatic stress disorder. And there's increasing research showing that in adults, but also in adolescents, that having frequent nightmares is an important predictor or strongly associated with risks for self-harm, including suicidal ideation and actual suicidal attempts. Now, I mentioned before that many people who experience nightmares feel that there's nothing to be done about them, or have come to learn that probably what I have to do, since it's a dream, is find out what it actually means, and maybe by working out its meaning, they will dissipate. But we now know, over the considerable research conducted, I'd say over the last few decades, that nightmares can be viewed and treated as a distinct sleep disorder, not a symptom of something else, but as a disorder of its own. And one of the better treatments for it, at least the one that is considered the treatment of choice, is known as imagery rehearsal therapy. It can be delivered in group settings on an individual basis. There's different variations to this therapy, but they all have the same core component, and usually it'll take anywhere from 1 to 6 sessions, so it is cost effective, quick, and efficient. In essence, what IRT does is has clients re-script their nightmares, which basically means having them imagine a different scenario in their nightmare. And what is important is what is suggested to them is to change the nightmare, to re-script it in whatever way feels right to you. And the reason that is important is sometimes when these techniques are reported in the media, they're presented as if the person needs to give the nightmare a triumphant ending, to change it to something really positive, and that's not necessarily what people choose to do. Some only change the beginning. Some may opt to change just a very small detail, a setting, a color of a wall, and some will, of course, also change the theme or the ending to something more positive. But the important thing here is the instruction that they change whatever feels right to them. And generally, there's a educational component that IRT will present to people about maybe what we understand about why people have nightmares, how they can be associated to other sleep disorders such as insomnia. But the core of the aspect of the treatment that directly targets nightmares includes these 3 main points: to select a disturbing dream, nightmare, and for those who have many, or those who have several related, for instance, to a traumatic event, to choose one of lesser intensity, and it's not a replicative nightmare that reproduces a trauma. Again, change this nightmare any way you wish. When IRT was being developed, often people were encouraged to write down the altered version of the nightmare, but right now the current practices are simply to have people rehearse this new dream in their imagination a few times a day. Twice in many cases is sufficient. Sometimes it can be a bit more. At any time that feels right to the person, and to do this on a daily basis. IRT has also been adapted for children, so young children can be instructed to try to change their nightmare and to do it via drawings. And there are at least 2 studies, both of them conducted in Canada, which show that IRT is an effective treatment for nightmares in children. So we know that IRT works very well in a majority of cases. 70 to 80% of nightmare sufferers report clinically significant changes following the use of IRT. It also effectively relieves various kinds of nightmares. So whether we talk about idiopathic nightmares, nightmares for which we don't have a clear understanding of potential underlying causes, recurrent nightmares, trauma-related nightmares, including PTSD nightmares. So there have been controlled studies on these various kinds of nightmares, and all of them point to the treatment's efficacy. But that's not all. Not only does IRT reduce the intensity and frequency of nightmares, but it also seems to then lead to other improvements in sleep quality in general. So people will report sleeping better, having more energy upon awakening in the morning, and sometimes there's also indirect positive impacts on other facets of their lives during wakefulness, so decreased anxiety, better mood, and things of that nature. So a very, again, relatively simple, cost and time effective treatment that works with a wide variety of patients presenting with nightmare-related disorders. So what this tells us is, with respect to these three parasomnias that we've just looked at, sleepwalking, sleep terrors, and nightmares, there's been considerable progress in our understanding about some underlying causes, why people have them, when they have them, but most importantly, that when they are correctly and properly diagnosed, these are all conditions that can be properly managed and treated, and that often these methods that we have at our disposal work well short-term, but also more importantly on a long-term basis. And so we can all look forward to this kind of more positive sleep than what parasomniacs tend to have. Thank you. Any questions?